Hello, I am Dr. Puramjai, pediatrician and neonatologist at Akkineni Hospitals. Trust you and your family are doing well. Let's go through some key insights today, so please stay engaged and make your notes.
Welcome to This Explainer. We're jumping right into a topic today that touches millions of families all over the world, autism spectrum disorder. But we aren't just going to look at what it is, we're zeroing in on something incredibly urgent. We're talking about the irreplaceable cost of waiting. Because you see, when we're dealing with a child's development, time isn't just a way to measure days or months. Time is literally a measure of developmental opportunity.
Here's our roadmap for today. We're going to cover 1. The cost of time. 2. Decoding the spectrum. 3. Spotting the early signs. 4. Clinical diagnosis. 5. Causes and myths. And finally, 6. Evidence-based interventions.
All right, Section 1, the cost of time, the critical window of neuroplasticity. 1 in 100. Think about that number for a second. That is the staggering estimated global prevalence of children affected by autism spectrum disorder. It's the most common neurodevelopmental condition we see in kids today, which means it's highly likely you already know someone or will know someone navigating this. But despite how common it is, we are facing a major problem with how and when we actually identify it.
And here is where we hit a truly tragic gap. On one hand, early signs of ASD are highly recognizable by the time a baby is just 12 to 18 months old. But on the other hand, the average age of diagnosis, for instance in urban India, is 4 to 5 years old. That's a massive, multi-year delay. Every single month that ticks by between a parent's first concern and a confirmed diagnosis is a month without intervention. And why does that matter so much? Well, the child's brain has this peak neuroplasticity window right from birth up to 3 years old. It's like a sponge. Missing that window is a missed opportunity for developmental support that you just cannot fully recover later on.
Let's move into Section 2, decoding the spectrum, what ASD actually is.
You hear the word spectrum thrown around all the time, right? Well, that word is absolutely critical. It completely shatters this old stereotype that autism looks exactly the same in every single person. Autism spectrum disorder is defined by persistent differences in development, sure, but it presents with just enormous variability from person to person.
Just consider the vast contrast you can see on the spectrum. You might have a highly verbal 10-year-old with exceptional academic abilities who profoundly struggles to grasp basic social nuances. Now contrast that with a non-speaking 3-year-old who can already read at their age level but literally cannot respond to their own name. Both of these children have autism. They look completely different on the surface, but both of them deeply deserve appropriate, tailored support.
So how do clinicians actually make sense of all this variability? They look at 2 core domains where these persistent differences show up. The first one is social communication and interaction. This could mean reduced eye contact, limited pointing, delayed language, or struggling with shared attention, like, looking together at a cool toy. The second domain is restricted and repetitive behaviors. We're talking about repetitive motor movements like hand flapping or spinning, an intense insistence on sticking to a routine, or extreme sensitivity, whether that's hyper or hyposensitivity, to things like sounds and textures.
Okay, Section 3. Spotting the early signs, red flags across developmental milestones.
Chronologically, these warning signs build up really clearly. By 12 months, if a baby isn't babbling, pointing, or consistently responding when you call their name, that's a flag. By 16 months, we're looking for the absence of single words. And by 24 months, the red flags include no spontaneous 2-word combinations. And by spontaneous, we mean they're coming up with it themselves, not just echoing or repeating phrases they've heard. We're also looking out for kids engaging in repetitive play rather than actually using toys the way they're meant to be used. This is a very clear developmental roadmap that parents and pediatricians really need to monitor closely.
Now, if you take nothing else away, please remember this. Regardless of age, if a child ever loses a language or social skill they already had, that is known as developmental regression. It is the single most urgent red flag in the entire spectrum, and it requires an immediate medical referral. No questions asked.
Which brings us to Section 4, clinical diagnosis, how we identify ASD.
Getting a diagnosis for ASD is purely clinical. There's no quick blood tests, there's no brain scan, and there's no single genetic test that can just magically confirm or exclude it. Instead, clinicians rely entirely on standardized behavioral tools. The ADOS-2 is considered the gold standard for direct clinical observation. It uses structured play to actually score a child's behaviors. They combine that with tools like the ADIR, which is basically a super detailed, structured interview with the parents about the child's developmental history. And then we have the MCHAT-R/F.
That's a brief screening tool primary care doctors use for toddlers. Now, if a kid flags positive on that screen, it doesn't automatically mean a diagnosis, but it absolutely means they need a deeper evaluation.
And a proper, comprehensive evaluation has to be incredibly thorough. You've got to include a hearing assessment. Why? Well, to rule out hearing loss. That can actually mimic social communication differences if a kid simply can't hear you calling their name. A full workup also involves cognitive assessments, speech evaluations, occupational therapy assessments to check out motor and sensory skills, and often genetic testing, like a chromosomal microarray, because genetic causes actually show up in about 15 to 20% of cases.
Let's move on to Section 5, Causes and Myths, Uncovering the Real Origins of Autism. When a family receives an autism diagnosis, you know what the very first question usually is, right? What caused this? How did this happen?
While science gives us a pretty clear answer here, ASD is a substantially genetic condition. We know this for a fact because studies show a 60 to 90% concordance rate in identical twins. That means if one twin has it, the other is highly likely to have it too. In most cases, it comes from this incredibly complex interaction of multiple inherited gene variants mixed with environmental developmental factors. There are also specific genetic syndromes, like Fragile X, that include ASD features. On top of that, spontaneous mutations, meaning gene changes that weren't inherited from either parent, account for a pretty significant portion of cases too.
And while we're talking about causes, I need to state this with absolute, unequivocal authority based on the source material. Vaccines do not cause autism, period.
This incredibly dangerous myth started from one single, fraudulent, and entirely retracted study. The lead author even lost his medical license over it. Since then, the scientific community has done exhaustive global research involving over 1.2 million children across multiple countries. The evidence is definitive. There is absolutely no association between any vaccine and autism.
All right, Section 6. Evidence-based interventions. Taking clinical action.
Look, while ASD doesn't have a cure, it absolutely responds to highly structured, evidence-based therapies. Early intensive behavioral intervention can involve 20 to 40 hours a week of structured therapy during those critical developmental windows to really boost language and daily living skills. Speech and language therapy directly targets communication deficits and sometimes even introduces alternate ways to communicate for non-speaking kids. Occupational therapy is there to help with sensory integration and fine motor skills, and honestly, one of the most brilliant approaches we have are parent-mediated interventions. Programs like Hanen or ESDM actually train the parents to weave therapy strategies directly into their natural, everyday routines. It makes the intervention incredibly intensive and super time efficient.
These targeted interventions are exactly why getting an early diagnosis is so absolutely critical. They're designed specifically to capitalize on the young brain's incredible flexibility, that peak neuroplasticity we talked about, from birth to 3 years old. When you get in there early, these therapies can dramatically improve a child's communication, their adaptive skills, and frankly, their lifelong quality of life. This is exactly why wait and see is never, ever a valid strategy when a child is showing developmental red flags.
There's this profound warning from Akkineni Hospitals that really hits the nail on the head. It perfectly summarizes everything we've covered in this explainer. Dismissing early red flags is a massive gamble with a child's developmental future. Waiting costs time, and when we're talking about neurodevelopment, time is the one resource you simply cannot recover. So, I want to leave you with this final thought to carry with you long after this explainer wraps up. Knowing that the brain is at its absolute most adaptable right now, and knowing that every single month truly matters, what will you do if you notice a developmental red flag in a child today? Awareness is an amazing first step, but taking action is what actually changes lives. Thanks for learning with me today.